Yes, clear.
Right, very good. Thank you for the introduction. Thanks everybody for attending, and thanks for answering those polling questions because it directed the talk. As we saw, most of us here tonight are not working with cardiac patients directly. So some of you who see the patients every day, their practice, and those who are cardiologists or cardiac intensivists might see this presentation as simple, but I think hopefully by the end, all of us will get some benefit out of it. Today, we're going to discuss how to stabilize and manage cardiac patient, pediatric cardiac patients. If you are outside a cardiac center, you don't have cardiologists to help you or even a cardiac surgeon to fix the patients. By the end of this talk tonight, inshallah, we're expected to learn a safe approach to management of patients with critical congenital heart disease presented at different ages and stages of their life. We also hopefully will learn something about how to recognize and manage the duct-dependent congenital heart disease and what is the best time to transfer patient to cardiac center. Should you transfer the patient immediately, as one of the questions said, or you should wait and stabilize the patient? Hopefully we'll answer this question by the end of this talk. So let's start with this. To be able to manage a child with congenital heart disease, we need to know what is expected from this pathology before it gets fixed by a cardiac surgery or intervention cardiologist. And to know what's expected from this lesion, we need to know the pathology itself. And to know the pathology, we need to know the physiology of this particular congenital heart disease, because each one of them has different physiology from the other depending on the anatomy. So in order to know the physiology, we need to know the anatomy very well. Even if you are not a cardiologist or a cardiac surgeon or cardiac intensivist, at least you need to know the big categories. The single ventricle with limited flow to the lung, single ventricle with unrestricted blood flow to the lung, biventricular lesions that need to be dealt with in terms of shunt, left to right or right to left, or valvular lesion. So having that in mind, the patient can present to your practice wherever you are, ER, NICU, or PICU, or a pediatrician, in three different categories. Either they have low saturation with adequate cardiac output, or they have low saturation with low cardiac output, or they have low cardiac output with normal saturation. I don't think there is any other different scenario from these three. And they can present at any age. The neonatal presentation of cardiac disease is usually critical and they need intervention early in life. However, good number of those cardiac patients present after 1 month of age, and you will be faced at one time with a patient who had a cardiac diagnosis, operated or not operated yet, and you have to deal with him knowing the diagnosis beforehand. So what support or resources you might have in your institute or hospital? So if you are lucky and you have a pediatric cardiologist available, he or she will be able to diagnose the patient, because one of the best thing about pediatric cardiology, it's one of the few pediatric subspecialties that you can figure the diagnosis within half an hour. You put the echo on the patient, you come up with the diagnosis, and you can know what's expected from this lesion, what's acceptable vital signs. So if you have cardiologist at your hospital, he will help you or she will help you to know this in advance, so that will help you a lot to manage this patient the right way. However, if you don't have pediatric cardiologists, which is the case in many centers outside the big cities, you will be the only one who deal with this patient. And I hope by the end of this talk, you might be able to manage most of the cardiac patients without pediatric cardiologist with you. The diagnosis of pediatric patient with congenital heart disease is not easy because the clinical manifestation, not easy for non-cardiologists, but for cardiologists, it's not very difficult. So if you're not a cardiologist, you don't know how to do echo, it will be difficult because the manifestation might be quite variable and non-specific. At the end, to know the diagnosis, you need an echocardiography to be done. With all my respect to clinical examination, hearing a murmur is just an abnormal sound. I'm not sure that anyone can for sure diagnose patient with just a stethoscope. This is one of the study that showed, it was published in 2008, 87% of cases of a new onset heart failure, pediatric patient, only reach diagnosis when the patient is in the state of severe decompensation. Some of them visited the ER 3 times before he was diagnosed with heart failure. And you can imagine heart failure, how obvious to us when we know the diagnosis, the examination is very obvious and clear. But in spite of that, good number of patients will be missed in first and second and third visit to the hospital. One of the good tool of diagnosis that we are all using is the newborn oximetry screening, which is now mandatory for all in ICU. However, you have to do it right to be able to get benefit of it, as this is one of the algorithm used in many hospitals. So you need to do it between 4 hours and 48 hours, and you categorize the patient according to the result. If it is more than 95, usually the patient is normal newborn. If it is between 90 and 94, you need to examine the patient again, record temperature, and repeat the measurement after 3 to 5 hours. However, if it's less than 90% and the patient is unwell or abnormal examination, you need to call cardiologist, because most of the patients will have a problem in their heart. However, even this good screening test has its shortcoming. This is Cochrane review for the pulse oximetry screening for critically congenital heart disease defects that was published in 2018. As you can see, this disease is very specific. Specificity is 99.9%. However, it is not very good sensitivity. It's only 76%. So you can overdiagnose patient because of this test, but unlikely you will miss anybody with congenital heart disease. If you are one of those who still believe in hyperoxia test, you can also use it. However, it is not an easy test to be done in neonate, because you have to do arterial blood sampling, and you have to give the patient 100% oxygen and interpret the result according to this table. However, if you have the facility to do the ABG blood gas, you can still use it, and it might help you to differentiate between pulmonary and cardiac diseases. So in the coming 10 minutes or so, we will spend some time discussing few diagrams of congenital heart disease, and hopefully you will have an idea what is the different type of congenital heart disease, how they present, what's the expected saturation, and what's the expected outcome from the medical management. So as we all know, this is the fetal circulation. You can see that in fetal life, the more oxygenated blood is actually on the right side of the heart, where the placenta supply the baby or the fetus, with a relatively better oxygenated blood through the umbilical vein, ductus venosus, IVC, then directed by the valve in the right atrium to the left atrium, then from the left atrium to the left ventricle, to the aorta, to the head and the body. While the blue blood that comes to the SVC, superior vena cava, comes to the right ventricle, from the right ventricle mainly to the PDA, down to the arterial system, then goes back to 2 umbilical artery, back to the placenta. After birth, this fetal circulation will change because the heart now is septated. So as you can see, and one of the best way to understand cardiac anatomy is to go with the blood flow. So this is the superior. Can you see the pointer, Abdullah, on the screen? So this is superior vena cava, and this is inferior vena cava, and this is the right atrium.
Pointer is clear, yes.
Okay, good. So the blood from the body, upper body from the SVC, and lower body from the inferior vena cava, mixed in the right atrium, goes through tricuspid valve to the right ventricle. And as you can see, the right ventricle is on the right side. We call it right ventricle, not because it's on the right side, because it's anatomically different from the left ventricle. It is trabeculated. It carries the tricuspid valve with it, which is a tri-leaflet. And geometry of the right ventricle is different. The right ventricle push blood to the pulmonary artery through pulmonary valve, and the blood goes to the lung, get oxygenated, and come back to the left atrium, from the left atrium to the mitral valve, to the left ventricle, to the aorta. And that's why you can see the blue blood, which is deoxygenated venous blood, is on the right side of the heart, and the pink blood, which is full of oxygen, on the left side of the heart. to be able to manage a cardiac patient, you need to know the pressure in the chambers of the heart. In the right atrium, usually the pressure is between 2 and 8. Right ventricle, it is usually 15 to 30 as a systolic, and in diastolic around 2 to 8, which is, if you look at it, compare it to the left side, it's usually 25% from the left ventricular pressure. Same thing for the pulmonary artery, slightly higher diastolic pressure. So the mean PA pressure in the pulmonary artery is around 10 to 15, something around this number. The blood goes to the lung, comes back to the LA, where you can see the LA pressure is usually slightly higher than the RA pressure, 2 to 10. That's why if there is an ASD, the shunt will be left to right. The blood goes down to the left ventricle because the EDB, which is the end diastolic pressure in the left ventricle, is less than the LA pressure during the diastolic part of the cardiac cycle. However, the systolic pressure in the LV is high, around 100 to 140, depending on the age, which push the blood to the aortic valve, to the aorta. And as you can see, the diastolic pressure in the aorta is around 60 to 90. That's why it's closing. When the blood goes down, it closes the aortic valve, preventing blood from regurgitating to the left ventricle. If you understand this pressure in the cardiac chamber, and you understand the different saturation each cardiac chamber, like this one, right atrium is around 75%, which is the same for the right ventricle and the same for the pulmonary artery. Blood goes to the lung and get oxygenated, usually above 95%, close to 100 in the right atrium. Same in the left atrium, 100, 75, 97 to 100. Same thing in the LV and same thing in the aorta. So you can see that the right heart blood saturation is around 75, while the left heart saturation is around 100%. That creates a difference of 25, which is the oxygen extraction at the tissue level. And that's why the mixed venous saturation is 75, which indicate a normal cardiac output. So if you keep this pressure and saturation and anatomy in your head, you will be able, hopefully, to interpret and manage different cardiac lesions. So let us start with very simple cardiac lesion. The ASD is an atrial septal defect, which is a hole between the two atria. The blood goes from the left atrium, as we mentioned, because the LA pressure is more than the RA. So the shunt will be left to right across the ASD. The right side will be dilated, but there is no desaturation. In fact, the saturation on the right side will be higher than 75. It will be around 80 to 85, maybe 90 in some cases, depending on the size of the ASD. This lesion usually does not present early on life, usually present after many years, and the treatment is, if not closed spontaneously, will be cath or surgical closure of ASD. The VSD is a systolic shunt, and it dilates the left side. It creates an early heart failure symptoms, usually after 4 to 6 weeks, when the pulmonary vascular resistance drop and more shunt from the left side to the right side goes on, causing congested lung and heart failure symptoms. Same thing for PDA. The two lesions, the VSD and PDA, share a lot of common manifestation and presentation in terms of time for presentation and manifestation. They usually require heart failure management early in life, and if not responding to medical therapy, they have to be closed either by cath or surgery. And the fourth lesion of this group is the AVSD, atrioventricular septal defect, or AV canal, or the Cushing defect as it used to be called in the past, which is common in Down syndrome patient. As you can see, it has an ASD primum and VSD and common AV valve. With most of the case, they will have valve regurgitation. So they will have symptoms around the same age after first month of life, with congestive heart failure, recurrent chest infection, failure to thrive, and they need to be treated for that before they go to surgery, and usually between 4 and 6 months of life, sometimes earlier than that if there is no control by medical therapy. So these 4 lesions usually present later than 1 month of age with heart failure, but they have normal saturation. They need heart failure therapy, and they need to be referred to cardiac center. These patients usually don't present in cardiac shock, but they present with chronic heart failure problem. So let us go to more specific and complex lesion. We'll take the lesion from the right to the left. So this is a lesion called tricuspid atresia, where the tricuspid valve is not formed. It's atretic, it's like a membrane. So the blood comes to the right side, cannot go to the right ventricle, so it has to go to the left side. You can see the shunt now from right to left. And you can see the pink blood and the blue blood are mixed together and they create something in between. So if the saturation on the right side 75, on the left side 100%, if we mix the two, you will get a saturation of 85, around 85. So those patients, if they have good ASD, good lung, they usually saturate around 85 all the time. No matter how much oxygen you give them, they cannot improve their saturation. These type of patients need an ASD. If they don't have a VSD like this one, they might need a patent ductus arteriosus. So the tricuspid atresia, if there is no VSD and no pulmonary valve developed well, you might need to start those patients on prostaglandin to maintain the PDA open for the blood to go to the lung and get oxygenated. So the saturation in these cases is around 80 plus minus 5. So if we go inside, so if the tricuspid valve is okay and you go to the right ventricle, you find severe pulmonary valve stenosis that will affect the right ventricular development. You will have a hypertrophied RV, small cavity, and high gradient across the pulmonary valve. You might have right to left shunt across ASD, but this type of patient usually does not need a PDA because their pulmonary valve is still can take blood to the lung and get oxygenated and come back to the left side. So their cardiac output is maintained. However, their saturation might not be normal, maybe high 80s to low 90s. However, if they have severe stenosis and a VSD and subpulmonary stenosis with hypertrophied RV and overwriting ventricle, aorta over the two ventricle, this changed the disease to something called tetralogy of Fallot. And as you can see, the blue blood is mixed with the pink blood, creating something in between. And that's why in tetralogy of Fallot patients, you will have saturation around 75 to 85, depending on the degree of pulmonary stenosis. And as you can see, because the pulmonary flow is restricted by a pulmonary stenosis, there is no way that this patient will present with congested lung. So very unlikely, maybe unheard of, that a typical tetralogy of Fallot patient will present with heart failure. Usually their heart is not big, but it's a boot shape because the right ventricle is hypertrophied and their lung is oligemic. So if you have a patient with right axis deviation in the ECG and oligemic lung and saturation of 85 and the patient is stable with normal cardiac output, this is usually a tetralogy of Fallot until proven otherwise. So if you have this patient with saturation of 75 to 80 and he's stable, you do not need to panic. Just relax and send him to cardiac center if you don't have a cardiologist to diagnose him. More severe right-sided lesion, the pulmonary valve is not formed at all. So this is pulmonary atresia, and this patient has no VSD. So this is called pulmonary atresia intact ventricular septum, pulmonary atresia intact ventricular septum. This is a very bad congenital heart disease of the right side of the heart because the heart has to, the right heart has to pump the blood to atretic pulmonary valve, so that there is no way for the blood to go to the left side except by an ASD with right to left shunt, mixing the blood to the left side, come out through the aorta and again goes back to the lung through a PDA. So this type of patient need a PDA. Pulmonary atresia intact ventricular septum is a duct-dependent cardiac lesion, and you have to start prostaglandin immediately to maintain the PDA. And this cardiac lesion is one of the difficult lesions that we hate in cardiac practice because some patients will have significant coronary-dependent RV-dependent coronary circulation. They are prone to ischemia and sudden cardiac death. The other type of pulmonary atresia is the pulmonary atresia VSD with MAPCAS, multiple aortopulmonary collaterals, where the pulmonary artery is small, our pulmonary valve is not formed, it's atretic, but there is a large VSD. So the blood comes from the tricuspid valve to the RV. Usually the right ventricle is a good size. There is a VSD that pumps blood from both right and left to the aorta. And because usually sometimes there is a PDA, sometimes there is to get closed before you diagnose the patient, but the patient will have a lot of aortopulmonary collaterals that maintain the saturation of this patient in the 80s until these collaterals get narrowed and sometimes closed by itself. Then the patient will have a problem if you don't do anything for those type of patients. So those type of patients, pulmonary atresia VSD MAPCAS, usually don't need, and actually most of the time, if not all the time, they don't need a PDA to maintain their cardiac output and saturation because they have enough collaterals to do so. So let us move to the left side of the heart. This is the extreme form of congenital heart disease. It's called hypoplastic left heart syndrome, where the mitral valve is small, the LV is small, the aortic valve is small, and the ascending aorta is small. So the patient with this heart, their blood cannot go to the systemic circulation from the LV. It goes to the right side through an ASD, as you can see in this bitter cartoon, and mixed with the right heart blood and comes out through the pulmonary artery. And in this lesion, the PDA will shunt from the pulmonary artery to the aorta. We call it right to left shunt, and supplies the head and the neck and even sometimes the coronary through this right to left shunt across the PDA. The saturation as expected to be in the 75 range, plus minus 5. And their cardiac output is maintained by the PDA. So those type of patients need a prostaglandin to stay alive until they have the corrective intervention, either by cath or surgery. Left side lesion again is aortic valve stenosis. This is on the left side is an aortic valve stenosis, severe aortic valve stenosis. The LV is still functioning well, hypertrophied. There is post-stenotic dilatation. However, in the extreme form where there is a critical aortic stenosis, the LV is struggling to push the blood against very stenotic aortic valve, and that will affect the cardiac output. So you need a PDA in those type of patients. So critical aortic stenosis need prostaglandin to maintain a cardiac output because their function is poor and their cardiac output is low. Until you fix this by balloon or even sometimes surgery, you need to maintain them on inotropes and prostaglandin. The most famous congenital heart disease that everybody like, but at the same time hate managing them because it's very difficult to expect what is the prognosis of those patients pre-op, is the transposition of great arteries. As you can see in this cartoon, the right side heart, the RV is giving rise to the aorta instead of pulmonary artery. And the left ventricle is giving rise to the pulmonary artery. So the two circulation are parallel. They don't talk to each other. So basically, this patient will be dead immediately if you didn't do anything for him, because the blood on the right side is circulating without oxygen, and the blood on the left side will circulate between the heart and the lung without going to the body. So what you need to do is you need to start prostaglandin to keep the PDA open. If it's not enough, which is most likely is not enough, if there is no ASD, you have to create an ASD by balloon septostomy before you send the patient after stabilization to the corrective cardiac surgery, which is the arterial switch operation after stabilization. If you are lucky, you might have this patient with TGA where he has an PDA, ASD, and he has also additional shunt, which is the VSD. However, the most important shunt in the TGA is the ASD. Remember that. So if you have a TGA patient, you started him on prostaglandin, he didn't improve, you treated him with intubation, sedation, inotropes, nitric oxide, and he did not improve, you have to do atrial septostomy as soon as possible to save the life of this patient. So we finished the inside heart problem. Let's go from outside. So this is a lesion where there is only one valve coming out from the two ventricle, which is truncal valve. It's called the truncus arteriosus or common arterial trunk. That trunk gives rise to one great arteries, then that will be bifurcated to pulmonary artery and aorta. This is truncus arteriosus with VSD always. And as expected from this lesion is considered to be a cyanotic heart disease, but in fact it has heart failure symptoms and cyanosis. Their saturation usually in the high 80s to low 90s. If the lung is good, there is a lot of shunt, you might have actually normal saturation in those type of patients. But usually they come in different shape and form. So this is type truncus arteriosus type 1 and 2 and 3, depending on the origin of the pulmonary artery from the trunk itself. Management of those patients, they don't need a prostaglandin. They might need to be treated for heart failure. Don't give them oxygen, give them Lasix, and send them for surgery immediately after diagnosis. Outside the heart, this is one of the common presentation of congenital heart disease. This is a coarctation where after the ductus close around 3 to 5 days of life, sometimes before that, the coarctations start to appear where there is a stenosis in the arch. So the blood trying to come out from the heart to the lower part of the body, it cannot because there is a stenosis. So you will have low cardiac output, ischemia to the gut and the kidney. Patient will present in cardiogenic shock, high lactate, low urine output. If you don't do anything, you might lose the patient. The LV will struggle, you will have poor function, and you have to treat him with prostaglandin, sometimes inotropes, depend on the presentation of the patient. More difficult arch problem is the interrupted arch, where the ascending and the descending are totally separated from each other, and there is ductus, we call it sometimes ductal arch, that supply the lower part of the body. And as you can see, for our colleague in NICU, because they use a lot the pre and post ductal saturation. So in this case, for example, if you measure the saturation in the right arm, you will have a normal saturation. If you measure the saturation in the lower part of the body, before you open the ductus, it might be normal. When you open the ductus, it might be normal or slightly less than normal. So it might be 92, 93, while the upper limb is 100%. Because in coarctation, when you open the ductus, you don't actually cause a shunt, you actually relax the coarctation area. So you might not have a significant right to left shunt. However, in this type of arch problem, the interrupted arch, if you measure the saturation pre-ductal, you will have high saturation on the right arm, but you will have a low saturation in the leg, okay? Because the right side is pumping blood to the ductus, to the lower part of the body. So usually the saturation in this type of interrupted arch is high 80s, sometimes 90s, but never be, you cannot have 100% in the lower limb with this lesion. But you can see, if you measure the saturation on the left arm, it's not accurate because the left subclavian artery might come from the normal ascending aorta, as in the left side cartoon, or it might come from the ductal arch, as on the right side or in the middle. So you might have low saturation in the left arm. So usually we depend on the right arm, unless you have also apparent right subclavian, which is very rare in this case. This is another type of interrupted arch with VSD. So usually those type of patient is more sick. They are usually small weight, and they need surgery in the neonatal period. So you need to start them on prostaglandin. You might need to start them on some inotropes. Avoid a lot of oxygen in this type of patient because you might worsen the lung congestion. The other type of cardiac patient who might present to you is total anomalous pulmonary venous drainage. And this is one of the patients that we presented in the polling question. Total veins that does not go back to the heart, to the left atrium, can go up. We call it supracardiac to the innominate, to the SVC, or it can go intracardiac to the coronary sinus, or it can go infracardiac or infradiaphragmatic, total anomalous pulmonary venous drainage, to the IVC. And this one is more likely to have obstruction or narrowing. Also, the supracardiac can have it. Very rare to have in the intracardiac type. And those type of patients, if they have obstructed total anomalous pulmonary venous drainage, you are not supposed to treat them with prostine. If you start prostine, they got worse, the lung got congested, you stop it with prostine because you make them worse, because you flood the lung and there is no way for the blood to go outside. And this is one of the few cardiac emergency that the surgery has to be done immediately to save the life of the patient. So after this journey over the cardiac lesion, let's go over some cardiac surgery that we do for cardiac patients. This is the hypoplastic left heart syndrome patient I showed you. How do we fix them? We do a surgery called Norwood, where we utilize the pulmonary trunk as aorta, and we divide the PDA here. We transect the pulmonary artery, we open the aorta, and we anastomose the pulmonary artery to the aorta with help of patch. And because there is no flow to the pulmonary artery, we have to create a BT shunt. So these type of patient, Norwood patient, or any type of patient with BT shunt, they usually have saturation of 70 to 80%. And they are fine. Their cardiac output is maintained. Their QB to QS is usually 1:1, maybe more or less, but usually their saturation between 70 and 80. So if you are working in a small city without cardiac surface, and you had patient, and you had a report that says he is a Norwood patient with BT shunt, he came to you with any disease, but his saturation between 70 and 80, you gave him oxygen, it did not go up. Don't panic. This is the acceptable saturation for BT shunt. After 6 months, we bring them to the cath lab, and if the pressure is okay in the pulmonary artery, we expose them to the second stage of single ventricle palliation. We call it Glenn shunt, which is anastomosing the superior vena cava to the pulmonary artery. You can see we transect the PT shunt that the BT shunt that we put on the first stage. So all the blood from the head and neck will go to the lung without going to the heart, while still the IVC blood goes to the heart. So you can imagine this type of patient still having desaturated blood mixed with the oxygenated blood going to the body, so the saturation around 75 to 85. So if you have a Glenn patient, please accept saturation 75 to 85 as long as there is no distress. You do not need to intubate those type of patients if they come to you with this saturation and they don't have respiratory distress. The last stage of the single ventricle palliation is Fontan. As you can see in this cartoon, this is a patient with hypoplastic right heart. There is no tricuspid valve. This triatresia, pulmonary atresia, hypoplastic RV. So he had a PT shunt first, then a Glenn, then Fontan. The Fontan is connection between the IVC, the inferior vena cava, to the pulmonary artery. So all the blood from the lower part from the body and the upper part from the body is going to the lung directly without going to the heart. The heart is a single ventricle used for a systemic circulation. So those type of patients need a good lung to survive. So if they come with a chest infection, it's not good for them because they struggle for their blood to go back to the lung. And their saturation at this stage is above 90%, unless they are fenestrated. Sometimes when the BA pressure is high, we create a fenestration between the Fontan conduit and the right atrium. And if there is a fenestration and the pressure is higher on the pulmonary artery, which is usually higher than the right atrium, there will be a little bit of shunt from Fontan to the RA, so their saturation will be in the 80s, sometimes even high 70s, but they have a good cardiac output. They are happy. So you don't need to worry about their saturation if they maintain a good cardiac output. Okay, so let us summarize what we have said. I'm sorry for this slide. I spent some time on it, but when I finish it, I find it not very helpful, but I'm going to show it to you anyway. So this is a pediatric cardiac patient comes to you, either neonate or infant or non-cardiac patient. They can have normal saturation or low saturation. Either one of them will have this presentation. The normal saturation can have low cardiac output or a normal cardiac output. The low saturation patient, they can have low cardiac output or no cardiac output as well. If they have a low cardiac output, they can have no cardiomegaly or cardiomegaly. And if they have no cardiomegaly, they can have wet lung or dry lung for both type of patients. So if you have low saturation patient, normal cardiac output, and no cardiomegaly, it could be tetralogy, triatresia, it could be truncus arteriosus, or TGA, or TABVD without obstruction. It could be PS or PA. As you can see, some of them will need prostaglandin to survive the first few months of their life, and some of them will not. So not very easy to manage those type of patients. However, if they are on the left side, where they have normal saturation with low cardiac output, with or without cardiomegaly and wet lung, it might be a coarctation of aorta, interrupted aortic arch, aortic stenosis, and cardiomyopathy. And you can see the first three, it might need prostaglandin, or may need, and for sure in the first two, aortic stenosis might not. Cardiomyopathy, they don't need a prostaglandin. But they can be one of those shunt lesions, like a VSD and ASD, valvular disease, post-biventricular repair with or without residual lesion, cardiomyopathy, or arrhythmia. So most patients, if they present with low saturation and low cardiac output, they will benefit from prostaglandin, especially if they are one of those duct-dependent lesions we're going to talk about later today. If they are known to have a cardiac lesion, they can be post aortopulmonary shunt like PT shunt or post stent of PDA, post Tiglin and post Fontan, and we have talked about the acceptable saturation for all of them. So they will have low saturation but normal cardiac output. So what is the duct-dependent cardiac congenital heart disease? It's the heart disease, the congenital heart disease that need a PDA to maintain adequate systemic or pulmonary circulation. So if you have a saturation below 70 with no improvement in acidosis or lactate, despite hemodynamic support or respiratory support, these type of patients are duct dependent, and you need to start prostaglandin to help them. Example of duct-dependent systemic circulation is coarctation of aorta, as we mentioned, critical aortic stenosis, and hypoplastic left heart syndrome. In those type of patients, you start prostaglandin and you aim for good cardiac output, palpable pulses, and resolving acidosis. If you achieve these three goals, you save the life of patient, and it's now time to send him to the cardiac center. The duct-dependent pulmonary circulation, like pulmonary atresia, critical pulmonary stenosis, tricuspid atresia, and those right-sided pulmonary circulation duct-dependent lesion require prostaglandin because they present after the duct close in the first week of life. And you aim for a saturation between 75, sometimes 70 to 85. You should have less than 2 lactate and a normal cardiac output without respiratory distress. If you are looking to this slide and you notice that the P and T on one line and the C is slightly anterior, I don't know if you notice this. Either you are a rare human being and you should be careful because we need to clone you, or you are obsessive compulsive disorder. You need to go to the psychiatrist. Duct-dependent systemic and pulmonary circulation. This is one of the lesions that are both systemic and pulmonary circulation require ductus, which is the transposition great arteries with restrictive circulation. And in this particular type of patients, you need to maintain the saturation around 80 plus minus 5, lactate less than 2. If you cannot do this with opening the ductus by prostaglandin, this patient need to go to cardiac center to have their atrial septum opened by balloon. But don't forget, not all desaturated patients are cardiac. You have to keep in mind if they don't respond to prostaglandin that they could be pulmonary hypertensive, primary pulmonary hypertension, they could be septic, they could have any metabolic disorders presented with low cardiac output, they could have primary lung pathology, they could have cardiac disease, but those type of disease that doesn't respond to prostaglandin as we speak to before, like obstructed total anomaly pulmonary venous drainage. And those type of patients, your aim should be to improve oxygenation, improve blood pressure, and correct acidosis rather than having a normal saturation, because it might be difficult. So the most important part of this talk is the prostaglandin, because as you can see from the previous slide, it's very important drug to save the life of those patients. So how much and when to start the prostaglandin? So if you have a congenital heart disease suspected patients, or he's antenatally diagnosed, he is well and non-acidotic, you can start a small dose, which is 5 nanogram per kg per minute. If the baby presented to you with absent femoral pulses, like in case of coarctation, but he is well and non-acidotic, you might start 20 nanogram per kg per minute. If he is acidotic, unwell, lactic or late presentation with suspected congenital heart disease, maybe it's better for you to start with a high dose, which is 50 nanogram or 0.05 microgram per kg per minute. You can double the dose every 20 minutes if there is no response or no improvement. However, the maximum recommended dose is 0.1 or 100 nanogram per minute. If you are using more than 0.05 or 50 nanogram per kg per minute of prostaglandin without seeing the improvement that you are hoping for, you need to discuss this with the cardiologist if available, or you have to move the patient quickly to cardiac center. Remember that prostatin can be given peripherally not only centrally, but also remember that as we and Dr. Ali were discussing before the presentation, prostatin is not dose-dependent response all the way. So you increase the dose from 5 to 10 to 20 to 50 to 100 nanogram, and usually the duct will open fully at this dose. So the duct is fully open. You cannot make it bigger. So at certain point of time, if you are administering the prostatin in the right way and the right dose, the response of the ductal tissue usually maximum at a dose of 100 nanogram. If you have a large PDA and the patient is not improving, it's not the shunt across the PDA, it's something else. It's either pulmonary vascular resistant issue or intracardiac shunt that's not enough, so you have to think of something else. Don't keep increasing the prostatin more and more, because you're going to have the side effect without the benefit from the prostatin. Don't forget that you might need to support the patient in terms of respiratory. They're on the prostaglandin. So baby usually on 10 nanogram or below, the risk of apnea is low and they don't need to be intubated even for transfer. So if you have a patient who is stable on low dose of prostatin, you do not need to transfer, to intubate for transfer. Actually, sometimes intubating patient for transfer is more risky than sending them on prostatin not intubated, because unlikely for the duct to close within 1 or 2 or 3 hours if the patient was on prostatin all the time for a few days. While if you intubate the patient, you are carrying the risk of dislodgement, and it happened many times that the ET tube dislodge in the medevac or in the ambulance on the way where there is no much of support for the transporting team. If there is apnea or symptoms of respiratory or cardiac failure, it's better to intubate and ventilate. And if you ventilate those patients, better to ventilate them room air. Just add oxygen if required to achieve saturation between 70 and 85. Don't aim for a higher saturation, because if you do so, you might achieve higher saturation, but on the expense of pulmonary overcirculation and low cardiac output, and the patient will have high lactate and acidosis. If you ventilate the patient, please give some analgesia plus minus some muscle relaxation, because it decreases the oxygen consumption and it improves the cardiac function. Monitor pre and post ductal saturation in those cases, and aim for PaO2 of 5 and PCO2 of 5. This is a magic number that is easy to remember. Sometimes with prostaglandin and poor function, you might need to support them for hemodynamics. So please secure an access. Usually better to have a UAC and double lumen UVC is ideal. At least 2 peripheral cannulae is minimum. And for our colleague who are not in cardiac center, who receive the patient for the first time in the NICU or in the ER, please make sure that you establish a good vein, sometimes even a good arterial access for those patients, because when they come to cardiac center, we have difficulty to establish lines, because they are usually sick, many days on infusion without good access. And if you miss the first few days, it's become very difficult to establish line later on. Treat hypotension with fluid, maximum of 30 ml per kg, except if the patient have contractility problems. If there is a heart failure or cardiomyopathy, they might not tolerate high boluses, so you have to be careful in those type of patients. But usually most of the cardiac lesion, especially those blue patients, blue babies, they tolerate high volume boluses. Treat resistant hypotension with inotropes. Usually people like to start dopamine in peripheral hospital, because it can be given in peripheral line up to 10 mic. And neonate usually respond to dopamine better than infant. So start dopamine if you don't have adrenaline, or go for adrenaline if not responding to dopamine. Other consideration for a patient who present to you with shock or desaturation: do culture, start antibiotics. And remember, sepsis can coexist with antenatally diagnosed congenital heart disease. They can have sepsis as well. Check blood sugar regularly, correct hypocalcemia and hypomagnesemia. Optimize acidosis with bicarb or THAM if the sodium is high. If pulmonary hypertension is suspected, start nitric oxide. Check temperature, avoid overheating the babies, treat fever, and sometimes you might consider to use therapeutic hypothermia in case of severe shock. Remember, you might need to transfer baby despite being still hypoxic and acidotic for urgent intervention, either by cath or surgery like balloon atrial septostomy, because there are diseases that are surgical. You cannot fix them with medication. You cannot fix obstructed total pulmonary venous drainage without surgery. You cannot fix restrictive pulmonary and systemic circulation in TGA with prostaglandin only if there is no good ASD. He has to have an ASD, otherwise he will die. So if you try your best and the patient is still not stable, try to move the patient as soon as possible to the cardiac center. This is one of the good guidelines that has been published lately in 2017 in the cardiology in the young by a group from UK, Europe, and United States about inter-hospital transport for a child. Please go and read this article. It talks about the same thing that we mentioned in the previous slides. We cannot leave this without talking about arrhythmia, although it's very rare in pediatric patients. So it's either slow with complete heart block or fast rhythm with like SVT, which is the most common tachyarrhythmia in pediatric, or abnormal rhythm like a long QT. And in this disease, the long QT, fix the electrolyte, start beta blocker. If you cannot handle the patient, refer him for EB management in cardiac center. Don't wait for long. However, the complete heart block, don't panic. If you have a patient with low heart rate, relax. Even if the heart rate is low, if the blood pressure is maintained, don't worry. As long as the patient is maintaining a good cardiac output, even if the heart rate is less than 50, relax and send him for a definite therapy in cardiac center. Don't panic. However, if there is a sign of low cardiac output with high lactate, low blood pressure, you might start medication that increase the heart rate like isoproterenol or isopril, or sometimes epinephrine. If you don't have isopril, you might start epinephrine that can increase the heart rate and maintain the cardiac output. If you don't have these two, or you don't get a good outcome, you can pace the patient externally, which is difficult to do because it burns the patient skin and affect the myocardium, but sometimes you have to do it. But you have to sedate and intubate and sedate the patient very well. And you transfer the patient as soon as possible to the cardiac center for pacemaker insertion. For tachyarrhythmia, the SVT is the most common. If they are stable, which is usually the case, they are having high heart rate but stable hemodynamics, try Valsalva maneuver by different ways. If not responding, you can try adenosine. But if they are unstable or they have clear atrial flutter, which is the commonest atrial arrhythmia in the neonate, they are very responsive to cardioversion. So please don't send them all the way to cardiac center. Just sedate them and cardiovert them. They usually revert to normal immediately. Remember that prostaglandin saves lives. So use it when you have doubt about any patient with suspected congenital heart disease. If patient not improving and the X-ray is getting more congested, the diagnosis could be TGA, and the patient might need septostomy, so don't wait. Or he might have obstructed TABVD, severe mitral stenosis with no ASD, or severe aortic stenosis, and usually the prostaglandin is not good for these specific diseases. So you might need to stop it and call for help. So to summarize, please make sure that you do no harm to those patients. Play safe, better to be wrong rather than sorry. Know the anatomy. Even if you are not cardiologist or cardiac intensivist, it's always important to know these type of complex congenital heart disease, at least the big category, the right obstructed, the left obstructed, the single ventricle, the biventricular heart. Discuss with cardiologists the expected trajectory for those patients so you can plan your management. Secure the patient's lines, please, and the tubes if needed. Know your resources and limitations, and call for help when you think you're stuck with what you can do. Thank you very much.
Amazing.
Yeah, thank you very much, Dr. Abdullah.